All right, recording has started. Welcome to your August Hope Board meeting. I'd love to have everybody in the room introduce themselves to everybody online, just to make sure you can see everyone in here and you know who's in the room. Because we have some attendees here in person that I want to make sure are introduced. So my name's Julie Arena. I use she, her pronouns. I work for the County Health Department with Coordinated Homeless Response. And I'm going to pass it over to Porter.
Hey, I'm Porter, and I use they, them pronouns, and I'm a new member of the Flexible Housing Subsidy Pool program and this whole initiative.
My name is Mark Edwards. I'm a sociology professor at Oregon State University. I use he, him pronouns, and I'm here representing the OSU Policy Analysis Lab.
I'm Paulina Kaiser, she, her pronouns. I'm the research director at Samaritan Health Services. I'm also here for the homelessness and healthcare data presentation in a little bit.
Joel Goodwin, I'm captain with Corvallis Police Department, and I'm a Hope Advisory Board member.
Thanks, Joel.
Rebecca Taylor, she, her pronouns. I work as a project manager for the Coordinated Homeless Response Office, and I will say, Porter, you are also part of the Coordinated Homeless Response Office and very focused on the FHSP, but you're one of the crows.
Nice.
I'm gonna move this down in case it will help. The owl will pick up on you, Rebecca.
Do crows and owls get along?
Birds of prey. Just saw that at the High Desert Museum. Okay, folks, we'll get it kicked off here. Thank you everybody for being here tonight. I'm gonna go ahead and screen share. Give me just 1 minute to get it all set up. Okay, slideshow. Well, let's make sure this is working. Okay, it is. Wonderful. For virtual housekeeping, if you can please keep yourself muted, and you can share your mic or not share your mic. And there's going to be time for public comment after we go over the agenda. So type into the chat if you have a public comment, and I'll also pause in case there's anybody who has called in and would like to make a public comment over the phone. Just a reminder of the agreements for the Hope Board culture and conduct that were made by Hope Board members, gosh, 4.5 years ago at this point, to be inclusive and curious and kind and respectful and open-minded. We haven't had food in a while, but we know that's a goal. And another reminder, I know folks can join in some meetings and then can't join in other meetings, but a reminder that our coordinated homeless response system includes Benton County, the cities of Corvallis and Philomath, and Community Services Consortium, and all are represented here. All right, for the meeting agenda today, after public comment, we've got some brief meeting business, and then there will be a community engagement session from our coordinated homeless response office team. At our last session for that on our flexible housing subsidy pool program. We've got a great educational component today for the point in time count, the PIT count, and thanks to our CSC colleagues for being here for that. And then our community progress update is on our homelessness and healthcare data, the healthcare services utilization among people struggling with homelessness. We've got great guest speakers here tonight to share their findings. All right, for public comment, I'm going to go ahead and stop sharing and see if we have anything in the chat. Is there anyone who is present today who wants to make a public comment? Okay, hearing none and seeing none, we will go ahead and do a little bit of meeting business. Oh, we got a person to admit here as well. Hold on a second, I'm going to stop sharing. Back over here. Nope, that's not what I want to do either. Sorry, folks, please be patient with me. I want to do the window. There we go. Okay. So meeting business, we had planned to have a co-chair election for Matt Easdale, but he is out of the country. He is in Montenegro and postponed from getting back from there. So we are going to postpone that election until the October meeting. There's an update on the business community representation as part of the Hope Board. We wanted to have a representative from the business community. And since Cindy Lowleak retired from the co-op in January, there hasn't been one. But I've continued to meet every other month with the Chamber of Commerce and Visit Corvallis, Christina and Christy. And I've asked them how they would like to proceed with this. They are comfortable sending someone from the chamber or Visit Corvallis to a Hope meeting to listen and report back, and also continue to meet with me every other month as part of the communication and representation on this topic, at least until there's any more policy-making recommendations to the city and the county. So they are comfortable with their representation at this point. Wanted to make sure to share that with the board. Roll call and meeting minutes approval. I sent out the meeting minutes for you all to review. Are there any edits or updates? I received none via email. And please speak up because I can't see all of you. Okay, hearing none, I'm going to go ahead and call your name, and please say whether you vote yes or no, or you abstain if you were not at the last meeting. Counselor Andrade.
Yes.
Thank you. Carol. Bruce.
Yes.
Alice. Brian. Cade. Sarah.
Yes.
Anita.
You bet.
You're actually the only person that can see. Barbara, I have you as excused in case the internet is working, but are you here?
Abstain. Julie, we can't hear you.
That's me.
Barely.
Didn't do anything to the owl, I swear.
Oh, now
That's
we can hear
better.
you.
That's better.
I'm gonna put a phone on this HDMI cable and we are not touching it. We're good on sound? Okay, great.
Yep.
And abstain because I wasn't there.
Thank you. Bria abstains. Barbara abstains. Ari, I called your name, but I think it was during a time when you couldn't hear us.
Correct. Yes, I approve.
Thank you. I'm gonna go ahead and screen share again. Thanks again for your patience, everybody. Okay, Rachel. April, can I ask, are you here in her stead?
I was not asked to be a delegate in today's meeting.
Okay, thank you for being here. Dina.
Abstain.
Thank you. Andrea.
Abstain.
Ilea.
Abstain.
Mark.
Yes.
Chris.
Yes.
Nancy. Right. Thank you, everyone. Your meeting minutes have passed. And let's go. Just a reminder of where we are in the year. Today's meeting is the final community engagement session with the FHSP. In October, we'll have an update on severe weather emergency response plan. And we will continue to seek input and participation from HOPE members as we move along. Okay. I'm going to stop sharing for a second just to make sure everyone can hear us okay in the room still. Yes? Okay, great. Before we dive into a wonderful presentation and nobody gets to hear it. All right, coming back to the PowerPoint. So today, Rebecca and I are here to give you an update about the funding we got from the state, Oregon Housing and Community Services. We've given updates and gotten feedback January and March and May on different funding streams from House Bill 5019 and also the Oregon Housing Rehousing Initiative, the ORI funds. And as part of that funding, launching the Flexible Housing Subsidy Pool program. And so we have updates on that and feedback on that. I'm going to pass it to my colleague, Rebecca.
Thank you. Yeah, so we just wanted to go over the information that we shared at previous meetings, kind of the overarching structure of what we hope to accomplish with the flexible housing subsidy pool as a addition to the existing service provider network in our community. So really this graphic is to help illustrate how the flexible housing subsidy pool provides centralized communication and coordination across different housing supports and services and those systems that serve people who are experiencing or at risk of homelessness. And so here we really, show that we know that there's pretty much, I guess you could say, the three-legged stool. We have the, in this instance, we have the housing support services. So being able to leverage the various different housing navigation supports throughout the community to get that centralized for a person to be able to access those services as they're navigating out of homelessness. The case management services to support them when they are placed. The street outreach to make contact to people who are experiencing homelessness where they are at and get them connected to the housing navigation and outreach case management services. In addition to that is the landlord engagement incentives, working with landlords as service providers as part of our homeless response by providing education both ways and understanding what they need to be partners in this response. In addition to that is being able to have sustainable, accessible program funding that is very flexible to fill the gaps in our existing services so that we can readily make available either housing units or be able to address barriers that people have, such as past rent debt or utility debt or other services and needs that they have that current program funding sources are not able to address. In addition to that is looking at ways to think creatively about the housing stock that we're using, because with the funding we're currently utilizing in the flexible housing subsidy pool, it has specific timelines to achieve goals. In this instance, housing and up to 51 households by June 30th, 2025. So knowing we have to find ways to utilize our existing housing stock. So how do we leverage that by both a public perspective and a private housing market and leveraging those stocks? And so really bringing that into this pool and providing that coordination, but also allowing our service providers to do what they do best and then bring the services in a coordinated way to the individual. And so when we were working through this, we really understood that there needed to be a specific staff structure that would be able to provide that coordination and centralized communication around the different services we have across different systems and programs. And so we identified a position of a program coordinator to support the program referrals and data collection along with communications and the outcomes of the program, both for the state, but for our community and where we as a community want to go past these one-time investments. In addition to that, we identified that a housing navigator was a key component of this that could really work with the existing navigation supports in our community to make connection quickly to the program coordinator's portfolio of available resources. And then, so we at this time felt that staffing capacity could be housed at the county within the Benton County Health Department. We positioned the program coordinator within the Coordinated Homeless Response Office and the housing navigator within our existing harm reduction team, which is actively working with the service providers and populations that we will be serving with the flexible housing subsidy pool. So there seemed to be, definitely an opportunity to leverage those additional relationships and trust through the harm reduction team. Then we move towards what types of community-based services do we want to lean on for serving the community within the flexible housing subsidy pool. So that was identified as street outreach to utilize the existing street outreach team that we have, along with the resource of the daytime drop-in center as a real key component of meeting people where they're at for those navigation and rapidly and emergency level responses. And then case management also was a service that we identified as being an important element to utilize community-based organizations' expertise and relationships and networks that they already had established through the housing and homelessness system. And so that's what we accomplished through the notice of funding opportunity that was released in April. And we'll follow up with more on that. And so as of August, we have now hired the housing navigator, Penny Blue, who has actually served as a harm reduction navigator, health navigator actually, and she had much experience with navigating people into stability and the resources that they needed through the harm reduction program. Was really wanting to explore what that next step was through helping people navigate into housing placement. So she expressed great interest in this program, and we now have her as a fellow team member supporting the flexible housing subsidy pool. I won't go into too much about Porter because Porter is here. And so we have the privilege of actually introducing Porter. But as mentioned before, Porter's role will really be, continued program development for the flexible housing subsidy pool and learning what types of systems we need to have in this structure to utilize the community-based organizations and their response, also ultimately to help people get housed. I will pass the mic over to Porter and let them, you already introduced yourself, but more detail as you see yourself in this position.
Yeah, I'm super excited to be here. I've been in the Corvallis community for about 2 years now. I came here with some pretty extensive DV advocacy backgrounds. However, working in an entirely different state with entirely different funding and approaches to things. I'm excited to be in this role because I've actually gotten to work with quite a few of the folks in this meeting on this board, and I'm excited to be in a position where I can provide value and support for the really important work that you guys have been doing and are continuing to do. And it's my hope that we can work together to really create and to continue creating some really amazing things for unhoused folks in this community. And yeah, I'm excited to be able to provide that help instead of me coming to you guys for help. I'm excited to be able to give some of that back. So.
And we are thrilled to have Porter here.
Thanks, Porter. And so then, in addition to the staffing structure for the flexible housing subsidy pool, the contractors through the NOFO process, we identified the Corvallis Daytime Drop-In Center to connect people experiencing homelessness with a system of care referrals to the FHSP. And then in addition to that, the case management to support people on their housing journey and continued sustained case management after placement and continued connections to the resources of the flexible housing subsidy pool, that is Corvallis Housing First and Faith, Hope, and Charity. We definitely wanted to have a shout out to the representation from the Hope Board that we had in the NOFO review committee. Looking back at as we continue to identify the Coordinated Homeless Response Office strategic plan priorities. One of them was, engaging the Hope Board to ensure that the county's response to homelessness through the Coordinated Homeless Response Office really had at the foundational level, ensuring equity, diversity, inclusion, and reviewing and giving feedback to specific processes of our program development. And in this instance, this review process really demonstrated that we were relying heavily on people who had have representation on the Hope Board and specifically had lived experience and represent the communities that have overrepresentation in our unsheltered population. So we really appreciated the time. There was quite a bit of reading assignments, and then also the review process in its own right took a lot of time. So the investment that you made to have representation during that review process was really important, and demonstrated us fulfilling the strategic priorities that we identified in our Coordinated Homeless Response Office 5-year strategic plan.
I'm gonna stop sharing for just 1 second, because Brian, I see that you joined, and Paula, I want to make sure that you mark Brian Cotter as present, and Brian, I wanted to check on your audio.
I can hear you loud and clear.
Okay, thank you so much for being here. All right, back to this. Thanks, everybody. Okay, what does it take to build a flexible program for housing? This is kind of a laundry list, but you know, when people are like, well, what do you actually do? What do you create? What are you working on? Like you say, you're receiving funding. What does it take for a housing program? Forms, policies, procedures, contracts, documentation, data collection. So Rebecca and myself, along with a whole bunch of other people in contracts and finance and admin and community partners, we've been working on this for a couple of months, making sure people's privacy and confidentiality are protected, making sure that we document homelessness so that we can abide by the funding requirements to get funding out for people who are unsheltered, doing outreach a ton to property managers, property owners, landlords, saying, hey, would you trust us? Would you give us the keys to the kingdom? How about 5 units? And all the procedures for referrals and contracts and funding stream tracking, building our internal system. And Rebecca Taylor, if she weren't here, this program wouldn't exist. Building relationships, pathways, communication systems internally with contracts and finance and admin and behavioral health. She has done the heavy lifting for almost a year now, but especially in this past summer and spring. And with HMIS, how do we track this? She has worked with the ROC to really figure that out, build out the projects, and then training for new staff. These are new roles and new staff in these roles. So building it as we fly it with the people who are learning how to fly it like we are. And then how do we do outcome measures? I want to thank Paulina because she's going to give us some consultant feedback on, hey, what do you want to measure? What does it look like? How do you track it? And build that in. And also giving huge thanks to, I'm going to say these out loud, all the acronym soup at the bottom, so everybody knows what it is. I'm going to say it slowly for our recording. Community Services Consortium, Linn Benton Housing Authority, Oregon Department of Human Services, Cascade West Council of Governments, Unity Shelter, Corvallis Housing First, Community Outreach Inc., Faith, Hope, and Charity, our County Behavioral Health Department, and a bunch of other community members and individuals who gave input on shaping these policies and forms, giving us examples so that we can create templates, and then just informing the program itself. That's a mouthful. It's been a lot of work.
Yeah.
Anything you wanted to add?
No, I just really appreciate you taking the time to read those out and not.
What are you guys doing over there? Well, a lot of stuff that doesn't equate to a person who's in a tent not being in a tent anymore in this very moment, but we need it all to be able to get the funding to do that.
Julie,
Yeah.
this is Carol. Has Rebecca or you or anybody been working with the NAACP Housing Committee?
Yes, we have. We work with Jessica Groom, and there's another person on the housing committee. We do. Yes.
So, because they're working on how to work with landlords, and they're finding some serious resistance from some of the landlords in terms of renting to people of color. So this seems like this might help support them at some point.
You know, that is a great thing to remind me of, Carol, because we haven't circled back with the NAACP contacts since we have been launching this program, and we had these conversations before in developing it. So thank you for the reminder so that we can touch base with them again.
Yep.
The conversations we had with them was understanding what their landlord outreach was looking like and what our landlord outreach for the purposes of flexible housing subsidy pool looked like. And so it was putting them in touch with the fair housing as well to understand where there might be opportunity for the initiatives through fair housing to make sure that landlords were complying with that when there was barriers for marginalized populations accessing those housing units. So at that time, what we were looking at as far as working with landlords to potentially have set aside units and specific incentives as it related to addressing some of the barriers that the people who would be navigating out of homelessness for the flexible housing subs fully realized they were related initiatives, but at that time it looked like that they would go down more leveraging through fair housing, and then we would revisit it as we move forward with this program.
Yeah, it would be good to go back with them because the last time we met, which was last month or something, they've run in some resistance from very specific landlords that, I just think having that connection and circling back and saying, well, how can we help or how can we work together would be really helpful. It's a small committee, as you know.
Thanks for the feedback, Carol. It would be good to touch base with them to coordinate again where we are at this point in time. Back to this fantastic visual that Rebecca and April put together. We have different funding streams and some that we've already received, some that go for 1 year or 2 years or 4 years or 5 years. Some are for staffing capacity. Others can be used for actual rehousing, like paying first and last month's rent. And then, so the first funding stream we got was House Bill 5019, and that was funds for sheltering, rapid rehousing, case management, street outreach, paying for rent. And the state followed up with another Senate bill for the Oregon Rehousing Initiative. We call it ORI. And it's to provide more funding for this same program, but to expand who can be served. We have a lot of families that are doubled up in one house, like 8 people living in a 1 or 2 bedroom place, and they aren't able to qualify for unsheltered homelessness. And so this second round of funding is really going to help us serve one of our priority populations from House Bill 5019, which was families with children. Did you want to add anything to that?
No, you're good.
Okay. Moving on. So our funding, this is just to break down in a little more detail. We've received some funds. Yay. Go team, go community. We've done some great things, most notably 50 beds coming back online from Unity Shelter for Room at the Inn and the men's shelter. And then us building this flexible housing subsidy pool and launching it. We have applied for more funds. We know that IHN is a key partner in this whole system and that they are really leaning into housing with the waiver and other flexible funding. So we've applied for the community capacity building funds to help get that new rental assistance waiver benefit out to the community. And we also have applied for the delivery system transformation funding, specifically for the landlord outreach, engagement, and incentives. Pauline was there for that presentation. And then we also plan to explore more. It's why we still have a grant writer, Libby Losky-Winter. We're going to be exploring different funds. I can't promise that we're going to go for any of these because you have to have certain capacity to go for anything. But there are some at the state and there are some at the federal level that we want to explore more. So we're not stopping here. We want to sustainably fund this program and serve more households. Okay. Some successes. I'm going to try not to cry. So the city of Corvallis, Brigitte, I'm going to ask you to share this first bullet point because boy, did you do the work. If you want to.
Sure. That's fine. The city of Corvallis, we purchased a building on 6th and Van Buren a couple months ago. We're working on rehab. The top portion of the building was a former Airbnb, so we're not displacing people, which really matters, right? And so utilizing that in the future, we'll be utilizing that in partnership with Benton County, who will master lease from us and use it as transitional housing. We have existing commercial leases on the first floor. Some of those tenants may choose to leave before the end of their term. We'll get design professionals in to rehab it to meet the needs of the population we're intending to serve. So potential single room occupancy on the first floor or transitional housing.
Thank you, Brigitte. Go team.
It still has work to do. So, I don't have people sleeping there tonight, which is regrettable, but we want to make sure it's nice and safe for folks so that they can sleep there in the future. So we have some minor and bigger repairs in the near future. And I would say we're all leaning in. Not one entity can address this complex problem alone. And we need all y'all and city government, county government, and everybody, IHN, Samaritan, to be working on this together. So lots of different pieces of the puzzle that come together and through lots of hard work collectively.
Thank you, Brigida. I'm glad you're here to share that. I do have some good news about heads in beds. But first, that second bullet point, Rebecca and team have done a lot of outreach to affordable housing locations, Brigida as well, and her colleagues, and it has finally yielded access to units. So an affordable development has said, yes, we will give you 5 units set aside for referrals from your program. So good news, we've had our first round of lease-ups. And our Corvallis McKinney Vento family advocates stepped up very last minute over summer break when they're limited to 10 hours a week and they had just lost funding. And the Corvallis Daytime Drop-In Center also came in to help with data collection and asking difficult questions for people so that we have the data that we need. And Corvallis Housing First for also stepping in with some referrals. And just to give a brief snippet of this, the landlord outreach and engagement to say, hey, we're launching a program. We'd love to set up MOUs. Would you think about in the future having some set aside units? Rebecca got so lucky that someone from a management company said, yes, we'll give you 5 units, but I need you to get families in by the end of the month. And we said, great. And we're not ready for that, but we're not going to say no. So we went ahead and just said yes. And because of this housing location having 2 and 3 bedroom units only, and because families with children are one of our priority populations from the House Bill 5019 local planning group, and because of the quick turnaround, we chose to ask our McKinney Vento family advocates that work with families with children experiencing homelessness to please help us get 5 families into housing immediately within 1 month, even before we had built some of the forms needed to be able to really launch this program, and before we had some of the staff capacity to be able to run this program. So this first round has been something of a pilot, and we're learning a lot as we go. But I have good news to share from it because as much as it has been for the past 2 months, here's some good news. Within 1 month of these families engaging with the flexible housing subsidy pool, all 5 families are housed. We have 5 units set aside, and of those 5 housed families, 6 adults, 11 children. And this is where I'm going to try not to cry, because those 11 kids are in beds and they have a roof over their head, and they didn't last month. And there's 10 more households in progress. And so as we are onboarding new staff and rolling this out, we're going to continue to have good news to share. And I wanted to note, Rebecca said this, and I'm really thankful you did, that this month is 1 year from when we heard from our House Bill 5019 local planning group that we needed this kind of capacity, that we needed access to units, and could the city and county please step in to get more access to units. And so we're doing it. Anything you wanted to add to that before we go to Q&A? Okay. So questions about the program. I'm going to stop sharing. That was a lot. That was a big update. I'm going to ask for any questions in the room first. And Joel, can I ask you a favor? Would you please close the door so we don't have to hear water maker? Thank you. Questions from our Hope Board members joining virtually today, or thoughts or feedback you had after hearing that update? Okay, I'm going to look in the chat too and see. Anything else we have in here? Yeah, April, thank you.
Hey, I'm not a Hope Board member, but I hope you'll allow me to pop in with just to ask a question that I think may be on a lot of people's minds. Rebecca or Julie or Porter and others, can you share a little bit about how we are moving slowly to start this program up and how things might look different in 3 or 4 months from now relative to the way that they look today. Because I know people are very excited about referrals, and we want to be mindful of capacity and where we are right now.
So this is an opportunity to kind of describe the intention of this program as well. So I might go around the question and then try to come back to it directly, but the intention of the flexible housing subsidy pool is not to create a specific housing assistance program all in one. It's not in addition to these others. You could go here, you could go here, or you go here. The purpose of the flexible housing subsidy pool is that we are making connections with the existing service provider network in Benton County. And so when we even use the phrase referral, when one might consider referral, they might consider, okay, well, if I refer somebody to this program, my job's done. They're going to be taken care of. I just document that they fully have been entered into the program, and then therefore they're housed. What we're really trying to do is that the flexible housing subsidy pool is the mortar between the bricks. And with that, we are trying to make it so that we can have collective impact and serve as many people as possible by leaning on the existing resources in our community, by helping making those connections. So how do we use existing rental assistance programs with the highly flexible funding that we have? How do we use the referring agency support services, the knowledge that they already have with the person they're referring to support that person, so that we're not fully taking on the entire, like, for example, our two staff that are our direct service staff are not taking on the entirety of the individual, but are able to make the connections to all the resources that that individual or household needs. Mm-hmm. And so learning that and developing the language around something that is so, in our systems, we're used to use the phrase siloing a lot. And often it's hard to even see the things in between, the space in between. And we are the space in between. And that is probably a very abstract thought to even think about. So to develop the tools to be able to effectively be that space and not end up accidentally positioning ourselves as just another siloed housing assistance program, it's going to take time to learn what that needs to be to stay flexible and, be able to move with the needs of the community and really leaning on those pillars, essentially, that all these other support services are already providing in our community. So I'll say that is that the intention is that we can help make those connections for a person, even if they're passing through briefly. Say it's the difference between somebody who just needs a deposit and we are the fastest person to be able to execute that and make that payment, pay off past rent, but then we're going to lean on, say, another service provider who has a more sustained rental assistance program. So that person is then going to be on the caseload of that service provider, but then also receive maybe those highly flexible funding sources. That being said, when people are being referred to us, we still are learning the way we navigate people through the system. And so 53rd Flats came before we had everything in place, but we didn't want to say no, as Julie said. And so we had some proven successes, which ramped up the excitement in our community with the opportunity that this might bring. And so I guess the message is please be patient with us. Know that when you are making a referral to our program, you are now positioning yourself as an actual partner to the program, and we'll be relying on you to work with the individual through a transition period, because that's another thing that we want as a flexible housing subsidy pool, that there are only warm handoffs. There are no just, anonymous, essentially drop at the front door handoffs. So that's what we're going to be learning and negotiating with everybody, is how do we accomplish this support as a safety net across the whole board. And that safety net includes safety net for our staff so that they don't get overwhelmed as well. So we're working on how to bring in referrals effectively, but also not hold people back, like if a referral comes to the flexible housing subsidy pool and the assumption is they're being taken care of, that we don't keep that person from being connected to other services in our community. I think that that was a really, really long way of answering that question, but that is a question that pries into a lot of different elements of the program. So I feel I had to go that thorough in order to answer it.
It's a great answer.
Thank you, Rebecca. I was hoping you'd say exactly that.
Okay, good. I'm glad we practice ahead of time.
Plant those questions. Other questions, or comments or feedback from the whole board? And I know we've come to you January, March, and May with this program to get feedback as it was being built. So none of this is new to you, but the good news is new, so that's exciting to share today. Okay, if there are no more questions on this, we'll go ahead and move on. Give me just a sec while I screen share again. Okay, just a community update. If you weren't here last time, we shared that on the website, our 5-year strategic plan is now up and the annual report from 2023 last fall is up. And we are working on the annual report for 2024. It's due this month to the legislature. And once that is done and accepted, we'll share that as well. And I just wanted to include our website again for people who are still transitioning to the new website for Benton County. I'd like to introduce our educational component, the point in time count. We have fantastic guest speakers from Community Services Consortium, Dina Eldridge, the Housing Senior Operations Manager, and Corey Hackstead, our HMIS Data Analyst Agency Administrator. And I'm going to go ahead and stop sharing and pass the mic over to Dina and Corey, and feel free to screen share.
All right. So I'm Corey Hackstead. I'm the HMIS data analyst for Community Services Consortium, and I also kind of gather some of the data for the PIT counts throughout the years. And basically, I pull everything from HMIS as well as the Counting Us app that's used by all 3 counties. And then from there, I basically download that raw data, so it's not gone through any algorithms. There's no, throwing or tossing out names and stuff because certain things weren't answered right. So this is just raw data. And then I basically put it into the different categories that the PIT count covers. And then as you see here, over here on the left, we have Benton County, and then I put up Linn and Lincoln just so you can see the difference across the different counties.
Corey, can I
yes.
jump in real quick for people who can't see those small numbers? And would you mind just saying out loud some of the total homeless numbers if you weren't planning to do that already?
I will.
Thank you.
So,
hey, Corey, sorry,
yes.
not to interrupt,
Go ahead.
but can we just start with showing everybody Benton counties?
Mm-hmm.
Maybe it'll make it by itself. Maybe it'll make it bigger if you have it. So
Maybe.
Since I know you're all interested in all of them, but you're from Benton County, so that's probably foremost in your mind. And just for while Corey's doing that, just for those that may not be familiar with the point in time count, I'm assuming most people on this committee are, but it is an annual census of the homeless in a community that is mandated by HUD. The numbers that result from that official count play heavily into funding formulas for both federal funding as well as these days state funding. And it is conducted, theoretically, it's supposed to be one night in January, but HUD allows us to count for 10 days in that month. And that is what we attempt to do. And we count people who are in emergency shelters, transitional housing for the homeless, and also people that are unsheltered, which is the unsheltered or street count, as we might refer to. So Go ahead, Corey.
All right. So here we have the Benton County numbers, and you can see that we counted 152 people that were sheltered, and that was either coming from HMIS or for shelters that were not part of HMIS. Then we had 268 individuals that were unsheltered, and these all came from the Counting Us app. As we scrolled down, for a ground total of 420 homeless individuals in the Benton County area. So moving down here, with the demographics and then are broken down into age groups, and we had a combined total between both sheltered and unsheltered. For those under the age of 18, we had 8. For those that were 18 to 24, there were 32 total. 25 to 34, we had 80. 35 to 44, 91. 45 to 54, we had 97. So you can see just from these numbers, our biggest population of homeless and clients is between the ages of 35 and 54. Then, of course, then you're tied with 25 to 34 at 80 and 55 to 64. There were 80 total. And then 65 and older, we had 30. Of all those numbers, when we moved down to gender, we had 134 women total, 265 men or man, boy, child, depending on what age they were. 2 transgender, 3 non-binary. Moving down to our race and ethnicity, we had 294 white, 28 Hispanic, 20 that were Black, African American, or African, 7 that were Asian or Asian American, 13 that were American Indian, Alaska Native, or Indigenous, 1 Native, Hawaiian, or Pacific Islander, and 21 people who selected multiple races. Following, we had some additional information. There were a total of 40 youths, so that's 24 and under. And then there were 38 veterans, 176 chronically homeless, 98 adults with serious mental illness, and then there were 67 adults with substance use disorder, 7 adults with HIV or AIDS, and then 40 adults that were survivors of domestic violence. And then for the city data that we were able to collect, there were 4 people from Albany, so that would be like your North Albany area, and then 264 out of Corvallis. So those are the numbers for Benton County from the raw data that I had available to me at the time.
And so obviously what you can see is these are just the people that our volunteers were able to find to complete the survey. So the surveys are voluntary. So undoubtedly SORT team and Corvallis Daytime Drop-In Center volunteers and others may have encountered more people who declined to take the survey. And I think some of the other things that do stand out is you see that there aren't very many people counted who are under the age of 18, so minor children. Does that mean that families don't experience homelessness in Benton County? Well, of course not. We hear anecdotally that families are becoming more and more prevalent and presenting more often at your local shelters. So most likely what this means, although we can't be sure, is that families may be more hidden. They may not be out where street outreach workers can find them for obvious reasons. And there's also probably a lot of families who transition in and out and stay doubled up or with family when they can, particularly in the winter time. Maybe they find a way to scrape by and get a motel every once in a while. But predominantly what's counted in this PIT survey, and this is true in the other 2 counties as well, are adults. But another trend that we've seen, and Corey's done some comparison going back, I think it was 5 years. Did you go
6
back?
years, yeah. 6 years.
Yeah. What stands out over and over again in this county and the others is that the highest percentage of people, at least that we survey, that find themselves homeless are in that middle-aged 45 to 64 category, which is obviously, unless it's a disability, too young for retirement, but maybe old enough to be experiencing health issues, be experiencing age discrimination in employment, and maybe they had jobs that they can no longer do. And so they find themselves unemployed without financial resources, various things that we feel are probably contributing to that age group experiencing homelessness at a higher rate than the others.
Hey, Dina, if
Mhm.
you're done, with the slides, could Corey stop screen sharing so we can see you better?
Sure.
I didn't know if you wanted to compare across the board yet or anything like that with these before I stop sharing.
Yeah, just in general, we can say that Linn County's numbers went up from the year before to about 500 total. Lincoln County's went up significantly. If you've read anything about the point in time count, especially from the last couple of years when we had COVID impacts, you've probably heard that Lincoln County on the coast in particular had severe undercounts. They used to be able to hold homeless resource fairs to facilitate their counts, but ever since 2020, those were not held. They did hold one last year, but it was organized kind of in a very short period of time, so there wasn't a great deal of attendance. But this year they made a concerted effort to really, with their 4123 group, get lots of community members out to really canvass that whole county. And as you can see, their numbers bear that out. They have a significant number of unsheltered people in particular.
So Dina, just so I'm understanding you correctly, it's not that all of a sudden there was a drastic hundreds-person increase in homelessness. It was that for at least this past year, the effort to count people, drastically increased. So it's a bit more accurate than it has been in years prior.
I will say that is for sure in Lincoln County. That's completely obvious. It's a 100% different, tenfold, I should say. Linn County, I think there was better effort too. It seems like when someone was asking us, how many volunteers did you have per county? And we thought, oh, that's an interesting stat. So we looked it up and then they asked, well, how does that compare to 2023? And we noticed that in Linn and Lincoln, obviously, the number of volunteers, because we have to know who the volunteers are when we use the Counting Us app survey. We have to get their names so we can see their numbers on the app. Those two counties had pretty good increases in their volunteers, but Benton County was basically the same amount of people as the year before. So yes, you've experienced increases. I think it's still safe to say homelessness is increasing. There's no two ways about it. It's not just about better counting. We all know that prices are going up. People that never had a problem paying their rent now do. So there's no doubt that homelessness is increasing. But in Benton County, there were basically the same number of people out counting. So, and there's other obvious things like you can see the two cities that were counted were Corvallis, all but 4 people, and North Albany, 4 people. There's no numbers from Philomath. There's no numbers from Monroe. There's no numbers from Alsea. And it would take, we tried to get volunteers in particular in Philomath. I don't know what happened with that. But on the other hand, in the past, I know I've personally been told by people who run like the food bank and the school district down there that there are no quote homeless families in Philomath.
Gina, I have some good news then. I just said it on a pick count meeting, thanks to Liesel, on your team. And the new executive director at Philomath Community Services was there, and she came from the Dells, and she understands how to leverage food banks in particular in our rural communities to try to help count folks experiencing homelessness in those rural areas. She's excited to be a part of the pit planning and strategize on those efforts. So I look forward to improved coordination and planning with our rural community partners.
Yeah, that will be great. And so one of the things that came out of last year is we tried the strategy of developing teams and team leads for each county or segments of each county, which worked pretty well. So even though it took me a bit to get it going, we also identified that regular meetings of those teams need to happen all year round. And so Liesel has finally gotten it on her plate. She just had her meeting. I think it was today or yesterday. And so we are going to start those regularly so that we're not just scrambling in 2 months to get this all put together. And another thing that a lot of people were interested in was they wanted to be able to hand out incentives to the people being surveyed. So whether it was gift cards or hats or whatever, the only problem is CSC's normal funding is very limited in being able to buy those kinds of items. So one of the things that these groups may want to pursue is actual fundraising ahead of pit counts in order to come up with the funds for those kinds of items or donations from, either the community or retailers or whoever who might be willing to give out those kinds of goods. So that's another thing we're hoping to improve on.
Thank you, Dina.
Mhm.
Are you ready for questions, or is there more you wanted to present on this?
No, that's fine. We'll take any questions.
Any questions in the room about the point in time, the pit count, or observations or thoughts?
I have a question. All 3 counties had some discrepancies between sheltered versus unsheltered, but it seemed like Benton counties had the greatest discrepancy. Have we looked into why that exists that way?
Do you mean more in shelter or more unsheltered?
Yeah, why? Yeah, that more. There seemed to be a greater distance between sheltered versus unsheltered for Benton County than for the other ones. Do we know why that is occurring?
Can you put the chart back up, Corey? Okay. So Porter, are you saying that there seems to be not as many people in shelter?
Yeah, well, it's so Lincoln Counties is like a 30-person difference, right? 244 sheltered versus 273. Linn Counties is a little closer to Benton's, but it's a greater gap there, and I'm wondering what's causing that.
I would say it's capacity of shelters.
So available beds.
Yeah. And then if there's no beds available, then they'd be unsheltered. So, and this data is coming out of HMIS. So whoever's putting, those data into shelters, provide the shelters had their data updated correctly on that day. There's that factor. There's also the factor of, it's just counting when you're out there. you're counting people that you're going out in the woods and other places that are not normally seen and stuff like that. Not necessarily are people going in camps. There's other locations they're counting people at during pit count that are not always serviced during a normal street outreach or stuff like that too. That could be why there's more unsheltered, because we were able to contact more people than we normally do because there's a concerted effort during this week that all that stuff's going on.
But
So that could be
I
some
will
of it.
say in this was in January, so I can't remember my dates, and we all know that OHCS is slow on their allocations, but was the men's shelter reopened by then, or was it still closed? That could have made a big difference.
I believe it was closed.
Yeah.
I'm not doing that.
No, so that's somebody else's mic, I think. That could have played a big factor into, because I recall looking at these numbers over 2023 numbers, and it did seem odd to me because it seems like the sheltered numbers were down, but that could, 50 beds not being open obviously would be a huge difference.
I'm gonna chime in here. The men's shelter reopened in December.
Okay.
Thanks, Ilea. I also, folks were commenting yesterday in the pit planning meeting, that this overlapped with part of the ice storm. And so especially for our rural areas, why there wasn't counting. And then also during an ice storm, people might be more likely to let a friend stay over, as opposed to saying, no, you can't stay here. I mean, I couldn't even walk out into my driveway. But I wanted to take note of what Brigida put in the chat, that there are shelter beds available today in Benton County that are open. And so for a variety of reasons, there are folks who are choosing not to come into shelter, even though we have available beds.
There, I looked at the data. There were also shelter beds available during that, around that time frame. I don't know exact dates, but.
Thanks, Brigida.
Yeah.
Other questions for Dina and Corey? Corey, would you mind stopping screen sharing so I can see everybody in the meeting? Thank you.
No problem.
Ilea, did you want to add anything after seeing those pit numbers? Or ask any questions?
No, I don't think so.
Okay, thanks for chiming in from Unity's perspective. Andrea.
I just wanted to add with that on this at the state level, the data indicate.
Andrea, we lost you. It indicates. We heard the data indicates.
And so it depends on the options that are available to people. So it's,
Andrea,
you know,
Andrea,
having.
Time out. We lost your audio right as you were just starting. We heard at the state level, the data indicates, and then we cut out.
Can you hear me now?
Mm-hmm, mm-hmm. We can.
Okay,
We can't anymore, my friend. I am so sorry. Can you put it in the chat?
about now.
Yeah. Yes, now.
Oh my God, sorry. I was running around doing stuff at 3rd Street. So at the state level, there's congregate shelter beds available all across the state. And part of it is because some people don't want to go into congregate shelter. And then some people would rather be on the street than be there. And it's not really, you know, so it's not necessarily attributable to like any time.
I lost you again, girl.
I wanted to provide some context.
Okay, I heard the context part.
Yeah, and I'll just chime in with our shelters in Albany often say that, well, we have beds, but they're all upper bunks. So people who can't negotiate an upper bunk bed can't utilize that bed.
Thanks for that insight, Dina. Andrea, was there anything else you wanted to add to that? I saw you rejoin.
No, sorry for the technical issues, but yeah, but what Dina said too is absolutely true.
Thank you. Other questions or comments from Hope Board members? Well, Dina and Corey, thank you for being here. We're going to transition to our next topic. I'm going to go ahead and screen share and go for it. Make sure you're seeing this okay. We've got great guest speakers here tonight. You have met two of them. Oh, I guess you've met Corey already, who talked about the point in time count. We've got Dr. Paulina Kaiser from Samaritan, Dr. Mark Edwards from H.O.P.E, the Oregon State University Policy Analysis Lab in the School of Public Policy. And Barbara, how is your audio tonight? Can I introduce you?
Can you hear me okay?
Sure can. I'm going to
Oh,
toss the
great.
introduction over to you then and let you share the background on this analysis.
Well, actually, Julie, if you wouldn't mind reading the the introduction, we just docked the boat and I don't have my script in front of me.
That's okay, don't worry about it. So the H.O.P.E board looked at quite a few different data points and policies and best practices. Captain Goodwin was a part of that, so was Barbara. And one of their first recommendations of their 12 recommendations is that we need improved data. We need to know what's going on, what's happening to folks. And that recommendation was finalized, gosh, it's 2024, that was in 2021, so almost 3 years ago. And that recommendation sort of gave the green light to H.O.P.E board members like Barbara and also city and county staff to really start making plans and doing outreach. And so we talked with Dr. Edwards and Paulina to say what would be possible. What would be possible to improve our data? So this is 3 years in the making from a H.O.P.E advisory board recommendation, the first one on data improvements. And I think this started 2 years ago. So we're thrilled to have you here and I'll pass the mic to you all.
All right, thanks, Julie. Yes, when we first heard about it, we thought it was possible, and we're going to show you today that it was possible. We have some results.
We thought it was possible.
We thought it was.
We weren't sure. We weren't sure if it was gonna work. So we
So
figured
you already know the main conclusion, it can be done. But we'll have some important things to report here to you today about the patterns of healthcare utilization among folks that are struggling with homelessness here in our 3-county area. So as the slide shows up front, this really was a collaborative effort between CSC and Samaritan Health and Oregon State University. So H.O.P.E board inspired it, advisory board inspired it, but we proceeded to work together to prepare this report. So this is a final report in the sense that we have completed this analysis, and you'll get a copy of the report very soon. That will have more detail than what I will present to you today. But also I would say, even though it's a final report, it's a pilot study. You'll see things that you wish were there. You'll wish some things were there that aren't there. And you'll also hear us say that we plan to keep going. We would like to keep moving forward with this project. So I'm assuming that we already agree that there's an association between housing status and health, and that those people that are struggling with homelessness and low quality housing and all kinds of housing difficulties are more likely to have health challenges, therefore more likely to need more health care, and particularly critical medical services such as having access to the emergency department or to the hospital. So there's a lot of existing research about this, that it does exist, that these linkages exist. We hadn't linked the data here to find out, well, what is the nature of that pattern in our region? So we were looking at this question of, to what extent do housing insecure people use hospital services? We focused on emergency department visits and on hospitalizations. And then within that question, we were interested in this idea of whether or not that use of these services is widely distributed across all people struggling with homelessness, Or is it the case that a relatively few number of people account for many of those visits? We get anecdotal stories. We talk to people working in the emergency department who say we see the same people over and over. We knew anecdotally that that was probably the case. What we didn't know was, well, to what extent might that be the case? So our project today is able to do that. So this covers Benton, Linn, and Lincoln counties. And then it also, like I say, comes with data that was available from these two partners, the Samaritan Health Services and Community Services Consortium. What you have is, on the one hand, Samaritan Health Services has the medical records of people who come to the emergency department or who are hospitalized. They have that information. What they don't have is information about all the housing services that people have received, or whether people are chronically homeless. Meanwhile, Community Services Consortium has all of that data, but they don't have the health records. And for all kinds of reasons you can imagine in terms of privacy and ethics and some of the things that Paulina will talk about, those pieces of data don't get connected very often. It's hard to do. So that's where staff from those two organizations, as well as my grad students and I, work together to bring those data together and be able to report those out, to examine results that would answer these questions that are here. The project was funded by IHN. So
Community Health Network Coordinated Care Organization.
Excellent. Thank
Like
you.
the SHARE initiative. Do you know that acronym? I'm not sure I even know that. acronym.
No.
Yeah.
Yep. So with
Wait,
that,
Bruce is on the call. I bet he knows.
in one of my classes, I actually have a whole glossary for students of all these acronyms.
We've got our
You do too. You do. So you gotta have this. So. All right. So with that, I'm gonna have Paulina talk about how the data were put together, and then I'll report to you the result.
Yeah. Thanks. So Mark already kind of outlined the challenge that there are a lot of kind of regulatory and just logistical concerns, and how to link this data that exists in different organizations and do it in kind of a safe and protected way. And so the solution, sorry, I put a lot of animations on this.
Really good.
Keeping your finger busy.
Yeah.
The solution is actually an analytic technique called privacy preserving record linkage, which relies on these cryptographic algorithms to convert identifiable information. So we started with raw data that had first name, last name, date of birth, and sex. And then you run it through these algorithms, and it literally converts it into a very, very long string of ones and zeros, which means absolutely nothing, is totally gobbledygook. But if you input the same first name, last name, date of birth into these algorithms, you'll always end up with that exact same string of ones and zeros. And so these algorithms are deterministic, but irreversible. I show you the ones and zeros, that means absolutely nothing to anybody, and no computer could like backtrack to the raw data. And so that's the technique that we leverage. So both CSC, thanks Corey, and Samaritan ran these hashing algorithms totally internally. And then that generated a de-identified data set, which was then emailed to OSU for the analysis. So a little more detail about the actual data. So Corey pulled out of HMIS information about clients served over the age of 18, served by the homeless services programs that CSA operates in calendar year 2022 across the 3-county service area. From Samaritan, we pulled data from our electronic medical record system, EPIC. Again, patients seen in 2022. We couldn't export data on all patients served by Samaritan, so we filtered to just look at patients that were flagged as homeless in the electronic medical records. I'm sure everybody here is going to understand that electronic medical records are not a great way to identify if somebody is homeless. But we do have a custom registry that looks to, I think it's like 6 or 7 different criteria. Thanks to Anita Earl for helping us put that together, like 2017-ish. So definitely not perfect, but it's a pretty good way to flag the indicators that are documented in an electronic medical record.
Ask a question before you said you couldn't run it through the entire.
Yeah.
population served by the health systems.
Yeah, just for logistical reasons, that's like 300,000 people.
So you just,
narrowed the pool.
okay, and specifically that had been flagged homeless.
Yep.
Okay.
Yep. And then, as Mark mentioned, that we focused on ED visits and hospitalizations because Samaritan operates all of the emergency departments and hospitals within Linn, Benton, and Lincoln County. So we have kind of comprehensive capture of the of those types of services. Obviously, that's not true for kind of outpatient services and mental health services. And as much as there's a lot of interest in understanding what's happening with those types of healthcare utilizations, we thought it was kind of better, again, from this pilot phase, let's try and just do something to start with the service utilization that we had complete coverage for.
Can I ask a quick question? Is this people who arrived at the ER and were admitted, or just anybody who showed up at the ER?
Yeah, good question. Just showed up at the ER.
Okay.
Yep, if there was an ED encounter, yep, in 2022.
Okay.
So these are the beginning of the results. So we have here, the first column that you see here is the Samaritan Health CSC data, SHCSC. You can see that we matched 775 cases. So 775 individual people who then, these are the characteristics of our sample. And the reason I show you this is primarily so that we can take a look to see, did our sample kind of look like what we might think is the population of people struggling with homelessness in our three county region. And so you see, you can just compare the first two data columns in terms of the distribution of persons across sex, race, and ethnicity. And then, and you see that generally the numbers are quite similar between the 2022 PIT count and our data, which was selected, sort of created differently in 2022. So you see some fairly similar patterns there. So that at least gives us some confidence that we have a group that pretty well represents the population of people struggling with homelessness in our three county region. Most obvious to observe is in terms of the counties represented, our sample tends to overrepresent Benton County. So that we can come back later to whether that makes any difference in terms of our interpretation of the results. I don't think it does, but it is important to note. And then also you'll notice that from the Samaritan Health CSC data, we were able to categorize people as being chronically homeless or not. And so if I could have you click on the button there, you should have a definition of chronically homeless shows up there in your in the little cloud on the
Can I
right.
read it for folks? who
Please
can't
do.
see that? Chronically homeless defined as lives in a place not meant for human habitation, a safe haven, or in an emergency shelter, and has been homeless and living as described for at least 12 months or on at least 4 separate occasions in the last 3 years. That's chronically homeless.
So that's an important thing to recognize here, that about a fifth of our cohort would be categorized by HUD as chronically homeless. I should also add that HUD also adds to that definition. They say a person has a disability and lives that. So there are really strict criteria for who gets identified as chronically homeless. But then the balance of the people in our group are people who had better housing than what was just described. You'll see, we kind of struggled what exactly is the right phrase to describe. It's like not chronically homeless. But finally, on the right, I wanted to point out, this is the census data for the 3 counties from 2020, just to remind us again of something we've already mentioned here about the disproportionate representation of particular groups that are homeless. Is a little bit squishy, hard to see here just because the different categories, but what I would just point out to you is that the group of people that are Black, Native American, and Native Hawaiian represent 10% or 10.5% of our sample, while only 2.5% of the local population. So we're getting hints of this, of the very thing you all know already exists. So I point most of this out to you as a way of saying, we feel pretty comfortable that this sample represents the larger homeless population. And then as we get to the end, I'm gonna give you about 10 more caveats of why it doesn't. All right, but we at least felt comfortable to go forward with this, to show, to take a look at hospital services utilization. So here we go.
Sorry, did I?
Your timing was perfect. I'm about ready to speak. There we go. So, in this figure, what you see on the left are chronically homeless. In the middle, that other group, the other 80% that for now I'll call housing unstable. And then over on the right is the general, the general public. So first to notice among the chronically homeless, over 40% of the people that are designated as chronically homeless made 2 or more emergency department visits. You move to that, so that's the dark bar. As you move to the right, the housing unstable group, still almost 30% made 2 or more visits. But less than what we saw for the chronically homeless. And then when you look far to the right, among the general public in the United States, you see that those numbers generally don't reach that kind of level of use. All right, the people who make just 1 visit, kind of the same all the way across, but the people who use the emergency department relatively more, we see certainly a relationship between what we might think of as sort of homelessness acuity, maybe, sort of chronic versus unstable, versus the general public. Okay, so again, the data are showing us kind of what we knew anecdotally, but now we have a count. Now we can say, well, 40% of the chronically homeless make 2 or more visits, somewhat less for the next group. Hospitalization, this does not, we see the same general story. It's not quite as obvious perhaps, but again, many people who go to the emergency department do not end up being hospitalized. So we see the bars are generally shorter. But again, the chronically homeless have more hospitalizations than the housing unstable group. If you get 1 click there, you'll see something on the right. That's 1 or more. We can't find public information of the general public. And whether they have 1 or 2 or more hospitalizations, but 1 or more hospitalization is over on the right for the general public. All right, so on the hospitalizations, that's less of a, I'll say, focus now. We're going to turn our attention back to the question about emergency department visits, because this is where we often have a lot of questions about what's happening in our local hospitals. So in this table, what you see is, first of all, down the left-hand side, instead of me just splitting it out as 2 or more visits, now there's greater detail. So you're kind of looking at the tail of that distribution of people who might go 2 to 4 times, 5 to 6 times, 7 to 9 times. If I can have 1 click, I'll highlight that in that tail, you see that there's, first of all, quite a few people who make not just 2 or more, but who make 5 to 6, 7 to 9, 10 to 12, right? Next thing to observe there is that the chronically homeless folks, the percentages tend to be higher than the other group. Notice I made a typographical error. Now I call them housing unstable, which shows you the way we were kind of going back and forth, that it was a housing unstable, housing insecure. So, but the point is that the difference between the left and the right column shows, again, chronic homelessness has an impact all the way out through the tail of, even the people who use the emergency department quite a bit. Okay, so now this is the place where we talk about the question of use of, how many of those visits are accounted for by people. So this is a little bit of a mind bender, because on the right side, now, instead of talking just about people, we're talking about visits.
In the parens.
In the print. So what you see is that there was, in our cohort, that whole group made 1,546 visits to the emergency department. All right, 775 people, but we're in our sample. Out of that whole group, there were 1,546 visits. What you can observe now, as you look down on the right here, the way to think about that is say the first number over there under chronically homeless, 1%. What that means is that 1% of the visits were made by people who made just one trip to the emergency department, right? You go down to the bottom, 8%. 8% of all the visits were made by people who were there 13 or more times. So now, you look over to the right, you start seeing some much bigger numbers. Now, part of the reason those numbers are bigger is that there are more people who are not chronically homeless, that are housing insecure, right? So lots of people who go less frequently adds up to a lot of visits. But nonetheless, if I get one more click, here's the thing where we start to maybe use this table for understanding patterns of what's been going on. What we see is that 23% of the visits of all that 1,546 were made by 13 people, by less than 2% of the population made 23% of the visits. So this table allows us to start to look at, well, to what extent then are visits to the emergency department sort of disproportionately used or by a small number of people. So I won't go through, kind of all those comparisons, but if I get one more click, one of the things we can do is we can look at, I just go up and took everybody that did 5 or more visits. It turns out that 12% of our cohort account for 2/3 of all the visits. Right? So that gives you a sense of the kind of this, whether you call it excessive use, overuse, might call it people using exactly what they need, but it's a small fraction they're accounting for a big number of the visits. Okay, so with that kind of an analysis, what we think we have learned is first that in spite of us not capturing the whole story, we see that this can be done by linking these data. And now we want to get a fuller story, right? So we were able to do this with the data from 2 places. And so what we'd like to do in the future is, if possible, be able to link other data, such as Paulina mentioned, data from our county health department, because obviously some of these very people are in the, that is what some of the people that didn't even show up in our cohort, in our data, they're getting their health care somewhere else, and they haven't maybe even made a trip to the emergency department for all we know. So this is one of the things that we'd really like to move forward on with the next step. The other thing that we want to point out is that although that sounds like a lot, like, wow, 12% accounted for 66% of the visits, we don't know what the pattern is really for people who are totally fine with their housing. We don't know the extent at this point to what fraction of emergency department visitors account for all the visits. It might be that it's the same. I kind of doubt it, but it could be, or at least closer to where it might help us kind of put in context what we see here, so that we don't kind of go into saying, yeah, well, look, the homeless are the problem.
So like for people who are housed,
Yeah.
housing stable,
Yeah,
do they also have 12% of those folks
right, yeah.
causing 2/3 of the ER visits? Oh,
It's one of those, like, we didn't think about it on the front end, and as we got further into it, and actually in a conversation with another person, she said, my neighbor down the street lives in this lovely home, and she keeps going to the ER every other week. I think she's lonely, right? And so we don't know to what extent this is a pattern that is unique to people that are struggling with homelessness versus the general population. So that's something we want to work on next. We also did not calculate what this costs and what would be potential savings and all this kind of thing if we were able to reduce the amount of call it excess visits to the emergency department. So we did not do that in a future project. We think that that's something that could be done. But that's very relevant then to the last point, which I know is perhaps among some of you, there have been conversations about, well, if housing can help people to not need so much attention at an emergency department, is there a benefit, a cost benefit to being able to, well, as well as just the pure moral benefit, of helping people avoid being sick? We are at this point, we haven't solved that. We feel like we're contributing to the conversation, but we don't have the slam dunk answer at this point. And there are a couple of reasons for that. One would be, is the cause and effect. Like, well, how much housing will get how much health, right? And we don't know kind of, does this dramatically change people's health circumstances or only a little bit? We're unable to assess that with these data so far. So can we demonstrate cause and effect, and what is the size of the effect, even as if there is one? So this is, again, in research projects, of course, almost always what you find out is most of what you don't know, right? You realize, oh my gosh, there's so much more. So I hope you'll forgive us for that kind of being at some level. Our answer is we got to keep working on this. But on the other hand, we think that we've been able at least to demonstrate in our region some of the things which really we anticipated, that homeless acuity matters in terms of the use of hospital services, and that in fact a pretty tiny fraction of those who are struggling with homelessness are making a very large number of those visits. What we do with that, those are the policy questions to follow.
Thank you.
So questions?
Round of applause for your effort.
Fascinating.
There were a couple of questions in the chat. Let's see here. Can you tell us how you defined housing insecure?
So Corey, I'm going to let Corey comment here on, because first it was people who were included in the CSC data, and then it was also matched, of course, with the Samaritan Health. And then it's sort of anybody who didn't sort of meet that chronically homeless definition. So it was everybody else. But Corey, maybe you could comment on like, well, what kind of services
So,
that would be in
so
there?
for the purpose of this program, we only looked at homeless individuals, but we had to figure out not everybody is considered chronically homeless. So we had to kind of figure out how to differentiate between chronically homeless and non-chronically homeless, but also take into consideration, sometimes there's people that are doubling up. Sometimes there's people that are, for whatever reason, they're staying in another situation that most people would call homeless, but not federally would call homeless. So we kind of called them housing insecure. Does that help clarify that?
Thanks for taking the time to do that.
Yes, thank you.
Thanks for the question, Dina. Andrea put a article in the chat, a link to it, a research article with similar findings. Did you want to mention anything more about that, Andrea?
Just that I think it's so awesome that you guys are looking into this on a local level, because I think it informs our experience. And but some of this information too is, I mean, you can corroborate this data with national studies about the link between homelessness and ED utilization. I think the thing that would be great to know on the local level is the impact of not having mental health treatment options available for people at the ED, because my suspicion is that small number of people have mental health issues that just aren't addressed, that aren't, there's not options for them aside from the state hospital. And of course, you don't get to the state hospital unless you get charged with a crime. So, that's just digging into that a little bit more, I think would be really useful. And I just wanted to add one other thing, is that housing is a solution to this issue. However, our experience has been that it's not necessarily that people stop going to the ED if they're housed. It's more that there's somewhere for them to go to recover, so that they're not continually going to the ED for like wound care and things like that. Because usually if people are chronically homeless, they're pretty sick and they're still going to utilize a lot of healthcare services, but at least they have somewhere safe and stable to recuperate.
Thanks, Andrea. And also, I wonder, comparing, if you continue to do these comparisons, how things might change when the county crisis center opens for those folks who specifically are having mental health crises.
Yeah.
And there's nowhere else to go but the ER, so let's keep that in mind.
Yeah. Yeah, and just to respond to Andrea, I think it's a great point, and there is a lot more that we can do within Epic data to dig into why are people coming to the ED and to better understand those patterns of, was it a wound care thing that could have been treated in an outpatient setting or some other setting, or was it some kind of acute crisis in which the ED really was the appropriate resource? So there is more to do there, and that's definitely on the list for phase 2. And I'll take this opportunity to also mention to Chris Campbell that working with the Benton County Community Health Center data is also on the list for phase 2. So Chris, I'm going to email you next week and we'll.
No, we're meeting. We're meeting soon.
Oh, is Chris coming down?
Oh, yeah.
Oh, that's never mind. I'm going to talk to you next week then, Chris.
Barbara, I see your hand is up, and you put something in the chat too. So would you like to just share what you put in the chat?
Certainly. Can you hear me okay?
We can.
Okay, great. Yeah, just want to, for the Hope Advisory Board and others that are on the call or at the meeting, please keep in mind, this was a pilot project. This was a proof of concept endeavor, as Mark had said. We wanted to do so much more, but first we had to prove that it could be done. And Opal and Samaritan Health Services and CSE were able to do it. The second thing I wanted to say, and Andrea, I appreciate what you said so much. And I also wanted to give you a shout out that you are kind of the impetus for this whole project, because I remember a data meeting that we had over 2 years ago where you said, I think that there's just a few people that are utilizing the emergency department, and wouldn't it be cheaper if we just built assisted living for people like that? We're hoping that maybe this effort kind of helps add the evidence-based data, for making decisions like that.
Thanks, Barbara. Before we go to Sarah and then Anita, I just want to mention the chat for folks who can't access it. Dina said it would be interesting to study those in permanent supportive housing to see if these numbers changed for them, because those are people with high needs, and compare once someone is in housing. So thank you for that, Dina. Sarah and then Anita.
Yeah, I think this was actually just addressed a little bit, so maybe I'll just echo that. The thing that immediately came to my mind was for a next step, really looking at teasing out the reasons for the visits and the outcomes. So, for example, which maybe really are true emergencies, which might be like primary care visits, which might be mental health, addiction related, right? Like all those different pieces, because I feel like that really is just such an important piece to know, thinking about kind of where this goes long term.
Thanks, Sarah. Did you want to mention anything with that, or?
Just taking notes.
Totally,
Yep,
yeah.
taking notes.
Anita.
Well, I think I want to piggyback on a couple comments because, of course, managing our homeless outreach efforts, I have a lot of juicy information, and there's a lot in Epic that could be very revealing. And mostly, what we know is that we respond to the ED all the time. And why are the unhoused folks there? They're there because they don't have a primary care provider. They're there because they don't have an address where they receive mail. They're there because they can't afford their meds. They can't transport to the hospital. They don't know how to decipher information, and they're traumatized, right? So when you're housed, some of those questions are answered, but without the emotional support at the visits and the help paying the meds, we're still back to square one, right? Because even though we could give somebody a primary care provider, we have to go with them and encourage and fortify that relationship, if you will, so it could be utilized, where the ED is kind of like the fast food of medicine. They could just show up and roll the dice and get some help, and then they leave. So I think we know a lot about about the whys, at least anecdotally, and I do use some smart phrases with my team that could give us a little more than anecdotal data. Because every time somebody from Homeless Outreach sees someone, we get their trauma history, we get their financial history, we get a whole lot of information that we put in Epic that could be looked at in greater detail to support my anecdotal experiences. But I think we've done a great job the last couple years from a Samaritan end of it in responding to the ED. Of course, our goal was to decrease ED utilization, but really our goal was to help the unhoused folks increase access to care, right? To feel cared for, to make the care last and work. So I think that my team's got lots of information. I look forward to future partnering, and I think we have some answers already, at least light answers.
Yeah. Anita, you're also on my list for phase 2. So yeah, we'll have more conversations for sure.
I remember when I first started here 5 years ago, going to your meeting, Anita. It was you and Chiho and Miranda Miller and Paulina, and like sort of this first DST pilot. And how do we put this in Epic? How do we track it? Is it the daytime drop-in center address? What is it? You have come so far in 5 years. We have come really far on better documenting this and boosting Anita's team. Because I remember the first thing I heard in Corvallis was, can we clone Anita Earl? Make 10 of her. And thank you for bolstering your team, Anita, and doing more great work.
Yeah. May I piggyback one little point? I also wanted to mention that question about how will housing affect ED utilization. I'm in charge of our medical respite beds, and medical respite beds means temporary housing and placement. And everybody in one of my beds practically had ED access. The repeated ED visits, we place them in medical respite. Those ED visits erase because we've got not only the housing, but the case management support. So I think medical respite placement also gives us a nice window into how to affect change here. Thanks.
Thanks, Anita. Corey, I saw your hand up.
Good.
You're good? Okay, let's see here. Other questions from our Hope Board members? And Brian Cotter, I think you're still on the line, but I don't know if you're on shift right now. Did you want to add any of your insight from your perspective?
Yeah, I'm still here. I'm on shift. I'm not sure what insight I have to add right now in that aspect.
More just that you respond, you're a first responder, emergency responder, and you're taking quite a few people, real people, to the ER often. I didn't know if any of these findings spoke to what you see all the time in your job, or if you, I just wanted to pause and make sure you had an opportunity to chime in if you had any thoughts.
We do have a select few that we transport to the ED quite regularly, and there would probably be better ways to help them than taking them to the ED, but with our hands and our licenses with the state is that's the only option that we have, right? And we don't so I mean we do the best that we can, and sometimes it can be challenging.
Yeah, thanks, Brian. I just wanted to make sure to pause in case you had thoughts on that, because you are a person who works in this area. Other questions for the wonderful team of people here tonight sharing?
I just wanted to, I know that we're gonna follow up with a focused conversation too, you know, just based as like pre-policy, post-intervention strategies and different things like that. Just thinking about the different programs that have been rolling out in Benton County, I'm sure they're rolling out in other communities as well around community health workers. And there's been some, I think, DST grants around that. Has that been integrated, or maybe for phase 2? And I know you're saying all this. I was just kind of wanted to talk about that because that was really one of the components helping get people that case management support to get a primary care provider, and how that supports the person's health too, beyond, you know, helping also the housing component.
Yeah. Yeah, it's a great point. I don't think we've gotten very far in connecting those dots. I mean, definitely not in phase 1. And it's also because there is so much evolution happening, and especially with the CCO rollout of the health-related social needs and other sorts of benefits, and a lot of that work being built into Unite Us, which is still happening. And so I think there's a lot of potential that in, you know, a year that the data points will be much easier to connect. But I mean, it's a great point for us to be mindful of now, because I think that really gets it. Like, the ultimate goal of all of this is to better understand what types of services plus what types of people equals like the outcomes we want. And so being able to track the types of services and correlate that with then the outcomes is going to be really important. And I think that's so definitely on phase 2 list is working with Corey more to dig into understanding like which types of CSC services and how those relate with different healthcare utilization and cost patterns. So that, like, that's one thing we can do, but I agree there's a lot more in the CHW and kind of outreach with other traditional health workers and peer support specialists and stuff like that, I think is going to be important.
Andrea, you put something in the chat. Are you able to vocalize it for folks who can't read that?
Oh, I just said we're super grateful for all this work, and I know it's Paulina. You've been at this a long time, and Barbara, I know that you have been working with us on this too, and so it just helps validate the work that we do every day. So just really appreciative.
Any other questions or comments from our HOPE board members? Okay, well, thank you for being here. And oh, Barbara, please chime in.
Yeah, sorry, I just wanted to ask the HOPE board members. So this is funded through IHN. So there is a plan to go forward with phase 2. Paulina and Mark and Corey are already working on that. But this is the opportunity for the HOPE board members to offer up ideas and any other suggestions that might help or inform phase 2.
Well, not a HOPE board member, but Chris Campbell, you're here from our community health centers. And I know we're going to explore this conversation with our FQHC partners. Chris, I don't know if you're at a place where you can chime in on your interests or any thoughts you had. I can't hear you if you're trying to share.
I don't even know how he did that. He made his circle go away.
Can you say what a FQHC is?
A federally qualified health center. It is health services for people who have no insurance or undocumented. They serve everyone, regardless of insurance or background. Your computer is not. There you go, Chris.
Can you guys hear me?
Yes.
Okay, sorry about that. I'm sorry, I've got the computer super low and then I heard my name. So the question on the table is, are we interested in participating in, I'm sorry, can you repeat that? I got
No, one of our board members, Barbara, who was involved in this, just said, hey, here's an opportunity to voice questions and interest and future thoughts in this forum. And I know that there's interest from our community health centers in expanding on what was done in this first round. So I just wanted to pause and give you an opportunity to introduce yourself to HOPE board members who might not know you and share any thoughts you had about how we could improve on this study in round 2 or add data to it.
Yeah, thank you. So sorry, everybody. My name's Chris Campbell. I'm the Quality Improvement and Data Services Manager for Benton County and the Community Health Centers of Benton and Linn County. As Julie was talking about, yeah, we serve about 11,400 unique lives across all programs. Probably majority Medicaid population, and yes, we never turn anybody away for an inability to pay. Yeah, we're very interested in kind of participating and adding to this this data set and also gleaning what we can. One of the things that we focus on and FQHCs are really good at is kind of working upstream a little bit and avoiding ED utilization. So as this project came on my radar, gosh, a long time ago, yeah, my ears perked up, and anything that we can do to kind of put greater visibility into this, severely vulnerable population. These are the people that we're trying to move the needle on. These are the people that we're trying to get engaged in services and keep them out of the ED. So yeah, we're willing and excited participants as this moves forward.
Thanks, Chris. Sorry to call on you unexpectedly.
Sorry, my computer isn't working.
That's okay. Bruce, I saw that you started screen sharing, and I wanted to thank IHN for funding this work, and I didn't know if you wanted to chime in.
No, nothing to add, but it's our pleasure to contribute to this great work, and it's just great to see the support from the community around it.
Well, you're getting lots of thanks. The whole team and IHN and everybody involved in this is getting lots of thanks in the chat. So thank you all for being here. Any last questions or thoughts? Y'all done great work. I know you played the game without the rule book and you wrote the rule book. You've only done the first inning. We look forward to seeing the rest of the game and adding new players and scoring some points and really a lot of metaphors. I went to a baseball game last week. But thank you for being here. Thank you, Hope board members. Oh, Chris, I can see you now. There you are. And we'll go ahead and end your meeting a little early tonight. Thanks to all of our guests this evening. And I'll be sure to follow up to email out the report that Paulina and Mark have shared, so you guys can see it with all of the caveats that you heard tonight. That, it's a limited data set, it's the trial run, there was a lot to work out, and so this is sort of the first report, and so to see it through that lens.
And Julie, if I could just add one more thought to that, if folks have thoughts between now and, the next 6 months, please either, contact Julie or contact Paulina and share those thoughts.
Thanks for that, Barbara. I'll be sure to put anyone in touch with Pauline. Thanks, everybody. We'll go ahead and end your Hope board meeting for August. Thanks for being here. We will see you in October. Remember, there is no meeting next month. Take care, everybody.
Thank you.
Thanks, Bruce. Okay, we will end the meeting.